starting now. So we can now come to the main event to introduce Professor Ray, who has been a fabulous supporter of the group ever since we started. And he's formerly President of the Royal Society of Medicine, the section of otology. So we really are gifted to have Peter with us today to spare his time. In our humble opinion, he is one of the best experts in the world on balanced conditions. He's also a very nice fella to talk to if you have a consultation. So that's a double win of not only being a world expert, but lovely with his patients. So, Professor Ray, if I can let you take the floor now and talk us through recent progress in our understanding and treatment of common balance disorders, please. Thank you very much.
That's very generous of you, Kevin. Thank you very much for your introduction. Everyone hear me okay? Do you want just to hold your hand up? Yeah, excellent. And as Kevin says, my apologies that I've slightly double booked this afternoon. I got asked to give a talk in Mumbai in India this afternoon, and I just assumed it was to a small group of doctors. And they told me last week that I'm a keynote lecturer at a big international meeting at 2:30 this afternoon, which was fairly stressful because the junior doctors have been on strike this week. And so I was up very late last night on call as well. But I finished this talk for you at 1 o'clock this morning, and I've managed to finish the talk for India about 10 minutes before we started today. So there we are. Good. Well, welcome. Now, Kevin's given me a brief to give you information that's not normally available to the public. Now, with the internet, of course, everything's available to everyone to some extent. But this is a slightly different talk, and it'll be a little bit challenging for you at times because it is a slightly more technical and medical talk, and please forgive me for that. So if some of it goes over your head, just let it flow over. But what I'm hoping is that you can get an idea of how I, as a doctor, think, and maybe understand more about your condition, which I hope will take you to a place where you feel more empowered with your condition. And that's what my aim is this afternoon. A little bit of it I will have talked to you about before, but I know there are new members. But I've written a completely new talk for you today, and I hope very much that will sort of enlighten you. So we're just going to have a brief overview of what balance is. Can give you a brief introduction to physiological dizziness, and that long word basically means what we all experience, but it's a really good way of beginning to understand what happens when things go wrong. And then I'm going to divide balance conditions in a medical way into two different groups. Those where you have an acute episode, in other words, a sudden onset of vertigo, which is limited, and then the other group of chronic imbalance where you're dizzy and unsteady all of the time. And then later on, towards the end, at Kevin's request, and a very sensible request as well, I've spoken to the local hospitals to find waiting times so you know how long it would take if you want to come to an NHS service. I'm going to give you a little update on research, which I know some of you have been involved in, and we are so grateful, and some exciting research going forward, which is just possible. There might be one or two people who would be interested in getting involved in that, and that's potentially world-changing research for other patients. And then finally, just a comment regarding the BPC, which is quite exciting, isn't it? To maybe get a Vox Pox for us. We can have on 5 minutes of fame. So let's get going. BBC World Service interview, Rupal has very eloquently introduced to us, and they're going to be looking for people who have an experience of dizziness in the past. And I think they'll be looking for you to really say, you know, how it's affected you, what it's done to you, and what questions you have to try and understand it. But because it's going to be a Vox Pox on a radio program, it's got to be really concise. You know, you just have a few seconds to say what you want to say, and really say it from the heart, and then we'll see what they select. I have no idea what they're going to do with the data, but all of the TV documentaries and radio documentaries I've done in the past have been very ethically and very carefully followed through. And I've got the media section at University Hospitals of Leicester, who are the sort of legal overseers. They're going to come over, meet everyone. So it's all going to be done completely properly. And I'm very, very careful with confidentiality and so on these things. So we'll come back to that right at the end. Okay, here we go. So this is Andrew. Andrew, I can't see you. I know you're here somewhere. I saw your name pop up. Good afternoon. Really lovely that you've joined us today. So Andrew Hugel is also a great friend of balance and a great professor and scientist and entrepreneur and great thinker in balance. And he came up with this idea a number of years ago, and it was Andrew's idea to have a balance disorder spectrum. You see, with some others, we put this idea together to show that balance can occur from the inner ear, from the brain, from the heart and blood vessels, and from other places. And symptom-wise, you can get vertigo, which is, if you like, an hallucination of movement, disequilibrium, you feel unsteady, and lightheadedness, you feel you're going to faint. So the orangey bits are those fainty feelings, and if they're dark, it's really common, and if it's light, it's really rare. So you get an idea that all of these different types of the body function can go wrong to produce a range of different things. And if you Google the balance disorder spectrum and put Andrew's name in, you'll get this up, and you can click on benign positional paroxysmal vertigo, and you get a little paragraph on it there as well. So it's a nice way just of seeing the huge range of different disorders. It's not that you're dizzy, it's there's an underlying problem there. And as doctors, we want to try and find out which, or maybe several of those things that are causing us symptoms, so we can then address them. So let's go to some dizziness we all experienced. Now, we all remember this picture, don't we? New York, 1930s, I think it was, 850 feet above the Manhattan skyline. Now, I don't know about you, but I'm looking at that picture and my feet are tingling and I'm beginning to sweat. And I really am beginning to sweat looking at this picture because I'm slightly visually dominant in my balance. And this is a physiological form of dizziness. There's no way I could go off on that beam. Absolutely no way. I'd be utterly terrified of falling. And that brings in one of the concepts of balance, that anxiety and stress do contribute to dizziness, or can be caused by dizziness as well. But it also introduces a second point of how important the visual system, your eyesight, is in balance. Because I'm looking at the computer here, and if I just look at my wall over there, the image moves across the back of my eyeball, across my retina. And my brain is able to tell there's a different distance from here to here and here to here. And that depth allows me and assists me in balance. So I'm absolutely fine here. And you can actually do this yourself at home if you want. If you stand up and just walk across the floor, well, you've just stood up and walked across the floor, that's fine. But if you visualize this beam and you see it on the floor and you see 850 feet below you, and you can do this, and I will have done it to some of you in clinic, I know I've shared this with you, then what you do is you tense up and you start sweating and you get goosebumps and your knees bend and you stoop forward and you stiffen. And that's what happens in lots of balance conditions, particularly persistent postural perceptual dizziness, for example. So it's a natural human response. I don't have any balance disorder, but that happens to me if I put myself in that situation. So you can beginning to see how it is a sort of a natural response. And think about dizziness, seasick. I don't know if you get seasick, but I do. I've actually just booked a boat to go fishing somewhere rather nice. And I thought, oh, fantastic, it'll be great. And then I looked at how big the boat was, 29 feet long. Okay. Then I looked at the weather forecast where I'm going. The waves are 9 feet. I bought a couple of packets of Sonarazine, so I'll probably be fairly ill on that. But why am I going to be ill? Well, the answer is this, that there is conflict between my eyes and my ears, visual vestibular conflict. And that is the root of all balance problems. So if you're in your boat, looking at the floor of the boat, feeling rather queasy, the eyes, as you rock and you're looking at the bottom of the boat, the distance between your eyes and the floor don't change. So your eyes are telling your brain you're not moving, but your ears are telling your brain as you rock that you are moving. And that's what causes seasickness. And of course, what you then do is you try and fixate on the horizon, so your eyes and ears are telling your brain the same thing. So you can see when there's this conflict between eyes and ears, we start to get dizzy. So you're now beginning to understand the root of conflict of balance disorders. And here's a really easy win for you. If you've got dizziness, long-standing dizziness, and you've got varifocal glasses, well, your eyes are giving your brain variable information, as are your ears, because your ears are injured. And that conflict between eyes and ears causes balance disorder. So one of the simple things to do if you have a chronic balance disorder is get some reading glasses and some cheapo distance glasses while you recover from your balance disorder. So lots of simple things to start with. Okay, what do I do when I see you first? Well, I ask you about the first episode because I want to really grill you on it. I want to understand what triggered your balance disorder. And then I want to understand what type of balance disorder you have. And the way we start is dividing it between episodic intermittent dizziness and chronic ongoing balance disorder. So the episodic acute dizziness, in medicine by acute we mean short acting, might have been a really nasty severe bout of vertigo lasting several days that took you to bed, or it might be intermittent spins, say when you lie down in bed and roll over. So that's episodic vertigo. And then we have chronic, continuous over a long period of time imbalance. And that might be the consequence of an injury to the inner ear. So that starts dividing your potential diagnosis in two. And the thing about balance medicine is you can have both, and that makes it a bit more complicated. So what we're going to do is we're going to have a look at the four major groups of conditions that cause acute vertigo. That's short-lasting vertigo that may just be a one-off or maybe intermittent. And the commonest is BPPV, benign positional paroxysmal vertigo. Overall, the big studies suggest 2.4% of the population experience this. That's about 1 in 40 of the population. Okay, and there are other potential causes such as vestibular neuronitis, which is a problem with the nerve in the inner ear, Meniere's disease, and vestibular migraine, which also affects really significant 1 in 100 people. So let's go, oh, look at this, BPPV. Now, there's some jerky eye movements for you. So that's called nystagmus. And when I drop your head over the end of the bed, if your eyes are flicking like that, I'll say you've got a rare form of BPPV called lateral canal BPPV. And that's something that I would have to treat for you. So let's go on and see what we can find next. Now, there are lots of symptoms you can have with BPPV, and it might include dizziness lying down in bed, rolling over, looking up. You might use extra pillows and so on. So really common and really easy to diagnose. And we can usually diagnose it within minutes of you coming into the clinic room. So how many people get it? Well, we would say about 1 in 100 people get BPPV in any 1 year. About 1 in 40 get it at some time in their life. Although there are some papers out there suggesting as many as 1 in 10 people get it when they're older. So a really, really common condition that certainly gets commoner as you get older. And if you think, goodness, population of Leicestershire, 1 million, 1 in 100 people get it every year. Gee, that's 10,000 people a year. It's a lot of people, isn't it? And what causes it? Now look, aren't these beautiful? So these little chaps are called otoconia, and they're tiny, tiny crystals, 10 millionths of a meter across. You can't see them. We've all got them in our inner ear, and they're made of limestone and protein together, and they're very stereotypic in their shape. Gerbils have them, monkeys have them, even fish have them. If you go back to the Devonian period, where we branched, mammals and fish branched off, that's 350 million years ago. So they're pretty important to us because they've been maintained during evolution over 300 or 400 million years, but they still cause problems. And here they are, look, they've got this protein, sugar and protein matrix, and this calcium is laid down on top of it. Now, just put that calcium idea at the back of your mind, and we'll come back to that just in a moment. And there was a doctor in private practice in America called John Epley, who only 1980, so in most of our lifetimes, worked out what was going on here. Now, if we go down your ear canal, where you're not allowed to put cotton buds, through your eardrum, through your middle ear where your hearing bones are, you come to your inner ear. So let's go down to the inner ear, and you can see you've got a chamber here called the utricle. And when you put your foot down in your sports car, you're accelerating backwards because of the weight of the crystals in there. And if they break off for some reason, by gravity, they come and lie usually in this semicircular canal. So the utricle does linear acceleration and saccule up and down, whereas the semicircular canals do spinny head movement like this, or like that. And if they're in the wrong place, it gives your brain the wrong stimulation. So here's a very old member of staff, this is quite an old picture, having a Hall pipes test. And as her head is dropped down, her eyes start to spur, there they go, little period, and then you build up this spinning, dum dum dum, the eye spin. So any of you who have had BPPV, when I look into your eyes and you're feeling really sick over the end of the bed, this is what I'm looking at. But the complicated bit is there are 6 channels that the crystals can go into, 3 on each side, and they're all in different planes. And depending on what plane the channel is in, the semicircular canal is in, the eyes will spin in a different way, and we have to treat it in a different way. So if you have them in the horizontal channel, look at that. If it's on the right side, your eyes twist like that, or actually go horizontally like that, and then you lie on the left, they do that. So that lets me work out which channel they're in. And these are these canals here, and these are these crystals falling through them. And if it's in the more common one, the posterior canal, this is what I see. Can you see it's quite different? And so this gives me a really good idea of which treatment, whether it's an Epley maneuver, a Seamont maneuver, a barbecue maneuver, a head hanging maneuver. There's lots of different treatments I can give for this. And you have to work it out depending on which way the eyes are going. Here's the really rare one for you, called anterior canal BPPV, and you can see the eyes flicking down here. Oh, yeah, those ones are woken up as well. Okay. So, and we treat it with an Epley maneuver. So lie you down, roll you over, and try and get the crystals back in the right place. But there are 3 new treatments. I know some of you have seen these before, but let's go through them. So we have the TRV chair. Now, this is a particle repositioning chair, and this is me looking really, really scared because I wasn't sure I wanted to have it done and be thrown upside down. This is Liz, our long-suffering manager, who's always game, and let us throw her around. And what we can do, I'll let you listen for a minute. There we are. So what we do is we set the chair in the plane of whichever canal the crystals are in. And then by banging, if I'll just stop that. By banging, we can loosen the crystals, and then we accelerate the chair, which is incredibly heavy, in the plane of the canal to try and get the crystals out. Now, we don't have to do that often, but it's let us do a lot of research, and we've got some really interesting stuff that we're going to get out on that chair. Now, vitamin D, I'll have spoken to you about if you've come to me with BPPV, and there's more and more evidence that these crystals are not like rocks or diamonds, they're living parts of you, just like your bone is. So in a funny way, this condition of the crystals rolling around is a bit like osteoporosis of the ear. Now, it's not osteoporosis of the ear, but it's a really nice way of thinking about it. And we've found that people with very low vitamin D are more likely to get BPPV. In fact, in the UK, BPPV is commoner in the winter, interestingly. And we've also found if you've got low vitamin D and you take a supplement, it significantly reduces, doesn't stop, but it significantly reduces your likelihood of having further attacks. So we do recommend vitamin D. A lot of the papers talk of very, very high doses. I give slightly lower doses at the moment. But there are, if you've got very low vitamin D, you can certainly take a high dose to try and correct that. And this is, this is a bit of a nerdy research paper, but basically everything to the left of the line means reduction in BPPV with tablets. Everything to the right means an increase. And if you look at the average, it's sort of halving the amount of BPPV people are experiencing, looking at many hundreds of people who've been treated with this. So there is really good research evidence now. And very, very rarely we end up operating for this condition. And I've done, I can't remember, 40, 45 of these surgeries now, which is actually a really, really large number. But here is a CT scan, an X-ray scan, chopping someone's head off like this. So we're looking up from underneath their body, so body like this, and then this is the ear on the side. This is the mastoid bone behind the ear. And these are the semicircular canals in real life, and this is the posterior semicircular canal. So I drill all of this bone out here, and then I get access to the labyrinth. This is the brain here, so you're fairly close to the brain. But it's pretty straightforward stuff. And then I use a 1 millimeter diamond burr just to open up the posterior canal. And I thought you'd like to see this in sort of life, as it were. And this is one of my lovely patients whose husband was a very, very good sort of electronic sort of stuff. So he managed to edit this for us. And can you see this little tube in the middle? Just have another look. Just look there, that tube there. It's within this tiny, tiny, tiny tangent. This is a needle here, so you can hardly see the tip. Magnified massively, massively, massively. So I certainly don't have a cup of coffee or anything in the morning. You'll have pretty steady hands for this. But what I've done is used a 1 millimeter diamond drill to drill off the bone off the top. very, very gently open up this canal. Then I pack it with material to squash, there it is there, squash this tube. And this is where those otoconia, those little crystals run. And I can block that off and stop the crystals moving. And we do really well. Okay, so I thought we'd go through that condition in particular detail, so you sort of begin to get an understanding of how your balance system works and how the body works in real life. Now, one of the conditions that many of you will have experienced, not only to trigger chronic imbalance, but also to trigger BPPV, is either labyrinthitis or acute vestibular neuronitis. Now, most people seem to be diagnosed with labyrinthitis by their GP, and it's a term that's in common parlance, but actually you've not had labyrinthitis unless you've lost your hearing or had a significant reduction in hearing. So acute vestibular neuronitis means a viral inflammation of the nerve of balance as it goes into the semicircular canals, and that's the more common diagnosis. And both of them will produce sudden onset of really horrid vertigo, spinning and vomiting and twitchy eyes, those jerky eyes. But the labyrinthitis is associated with tinnitus and hearing loss, whereas the vestibular neuronitis isn't. And labyrinthitis is rare and usually much more severe. And if there's hearing loss, you really ought to be getting an emergency, into opinion, to get potentially to be given steroids or even steroid injections. So there are lots of different ways of managing that. But you can be really unsteady for days and weeks afterwards. And some people remain unsteady, in fact, everyone who comes to see me, of course, for months or years afterwards. And it can go on to cause other conditions like those crystals, BPPV, or persistent postural perceptual dizziness, which I'm going to talk to you about a bit later on. And you've got to be careful that it's not a stroke or a migraine that's caused it. So that's the first thing we have to exclude, although uncommon, but certainly not rare. And then we're going to talk thirdly, the third group I want to talk about is Meniere's disease. So whereas BPPV affects 1 in 40 people, roughly, Meniere's affects about 1 in 1,000. I can give you some really exciting data at the end of the session this afternoon on Meniere's disease. And you've seen this picture already. So if I drill in here, I can get into the semicircular canal for BPPV. But if I drill along here and open up the lining of the brain here, this is the back of the brain, then you get this view here. And this is the endolymphatic sac, which is where Meniere's arises from. There it is there, and that's it running in there. So you get an idea. This is an endoscope I've used. That's the brain here. And we can clip this off and do various things for Meniere's as well. So they have anatomical bits to them. And the way to diagnose it, you can either have probable Meniere's, where you have intermittent dizziness and fluctuating hearing and tinnitus, but we're struggling to find it. Or you can have lots of attacks of vertigo with hearing loss and tinnitus, where we call it definite. So you might be a bit surprised if you come to see me with slightly difficult symptoms when I say, you have definitely got probable Meniere's disease. Now, I appreciate that sounds strange, but that's because we're relying on these international data to make our diagnosis. But look, here's a really important concept in balance medicine. Just because you've got one condition doesn't mean you can't have others. So of my patients with Meniere's disease, it's fluctuating vertigo, hearing loss, tinnitus, and fullness in the ear, which is horrid, I mean, really horrible. 40% also have migraine. 20% also have BPPV. Everyone will have some unsteadiness related to it, and everyone will have an emotional reaction of some sort. And I will always say to you, you're not a robot. You're a human being. So you have to react to it in some way. And we have to address potentially each of those elements, not just the dizziness. It's much deeper than a simple treatment. Can you treat Meniere's? Well, yeah. And look, there's lots and lots of different things, from waiting to see what happens through to major surgeries opening up the brain. But our treatment really has changed quite a lot over the last few years. Medication for decades, we used beta-histine or beta-circ or circ. And it probably has a place, but there was a very big study a few years ago which showed if you took high-dose beta-histine, this is the number of attacks, then the number of attacks fell very significantly. Brilliant. If you took low-dose beta-histine, fantastic, the attacks fall away as well. But if you take a Smartie, the attacks fall away as well. So actually, the beta-histine didn't seem to be doing very much. Why's that happened? Oh, sorry. Oh, yeah, okay. So what we then moved on to was to see if different treatments would work. And the treatments that we found were really successful were steroid injections and gentamicin injections into the ear. And I was part of this, I think it's reasonable to call it a landmark paper, that was published in The Lancet in 2016. And we've carried on finessing the treatments over the years. And what we do is, just in the clinic room under local anaesthetic, put a needle through the eardrum and inject this very powerful steroid a week or two apart, which we do it twice. And it can be sore. We have 1 or 2 people a year who find it really sore. And about half my patients find it reasonably sore, but manage it. And the other half that don't find it too bad at all. And I think just about everyone's come back with a second treatment. So this is not a mock-up, actually. Believe it or not, this is my mother-in-law, and this is my wife. So if you've spoken on the phone to Yannette, that's her hand. Now, she is only pretending to put this cream in. She's not putting it in. I got my long-suffering fellow, Eugen, who's now a wonderful, wonderful consultant colleague, to do the injection. And Eugen drills out people's brains and does everything. And he said, Prof, I've never been so scared in my life as treating your mother-in-law. But anyway, there's him putting the injection in, and it worked. And these are the results we've got over very large numbers of patients. So the white line is gentamicin, which is sort of an antibiotic which destroys function, and we only use as a last resort. And the black line is steroid. So in the month before, from the big sample we took, people were having an average of 6 or 7 attacks a month before, and were having less than 1 after treatment. And in the 6 months, it fell from some 20 attacks down to just a couple of attacks every 6 months. So dramatic responses to treatment. And there was little change in hearing, which surprised us, because gentamicine's traditionally been associated with more hearing loss. But speech discrimination, in other words, how you can interpret sound, is a bit better with the steroids. So we always start with the steroids. And there you are at the end. That's my mother-in-law and that's my wife. So if you've ever spoken to her on the phone, that's who you've been speaking to. Okay, so let's go over to vestibular migraine. And this is the elephant in the room. It's really common. It's got lots of different types. And it's the commonest cause of vertigo after BPPV. Probably affects about 1 in 100 people. And so for every patient I see with Meniere's disease, I'll see 10 people with vestibular migraine, and often with both, just to make it even more challenging. And there's a group called basilar migraine, where it's the blood vessels at the back of the brain seem to be the cause, and you can get vertigo. But hey, look at this. Get tinnitus, sounds like Meniere's disease. Sensitivity to sound, sounds like Meniere's disease. Half of patients with migraine report some hearing loss with their attacks. Now we're getting really difficult, aren't we? Because it's so similar. But there are ways of distinguishing it. It's more likely to be on both sides with migraine, and you might get light sensitivity. And then we do some testing, specialist balance testing. It's really important to see whether you've got both conditions, or whether we can get evidence of Meniere's, because that's a very different type of treatment. But it can be a challenging diagnosis, and it's often missed. Now, the international, if you can't sleep, I recommend buying the International Headache Society Compendium of Headaches 2013. It's possibly the most boring book in the world. Anyway, it has a little bit on vestibular migraine, and I've sort of translated it into English. And it's more likely if you've got migraine. The time frame is very variable, actually from seconds or minutes to many days. And if it goes on for days, it's much more likely to be migraine than the Meniere's disease. And you're quite often some motion sensitive between as well. Often have a headache, but you do not have to have a headache to diagnose migraine. That's really important. 1 in 10 migraine attacks occur without headache, but light and sound sensitivity is common, and zigzag lines or kaleidoscopes in the vision is quite common as well. And goodness, we've got lots and lots of treatments. So we start out looking for triggers, dietary, cheese, chocolate, Chinese food, caffeine, citrus fruits, red wine, all of the Chianti, the red wine. So all the 6 C's of migraine, cut those out. And it's extraordinary how many people's lives have been changed just by simple dietary modifications, because all I drink is water. Wouldn't dream of touching caffeine or alcohol or red wines because of the potential triggers. And lots of other things, sleeplessness, some drugs do it. So there's a whole range of things we go through. And then we can treat it with the acute attacks. You might have a triptan, sumatriptan, for example, in your bag to try and treat it. And then we can have preventative medicines as well. And I don't give the preventative medicines initially. And even if I were to, I'd want at least 2 attacks a month before we contemplate it, because they have side effects. So amitriptyline and nortriptyline are our favored ones to start with at 10 milligrams. They can cause a little bit of sleepiness, and they can add a little bit of weight on occasionally as well. Antihypertensive, propranolol, you can't have that if you've got asthma. And if you've got a high-powered job and you're working hard, propranolol can just take the edge off you, so it's not ideal either. Pizotifen we use in younger people and get a bit of weight gain. So pyramate, we're getting really heavy duty here. Now actually you get some weight loss with that one, but that has side effects of tingling and various other things. So none of them are perfect, but together we can get the majority of our patients better from vestibular migraine. Not necessarily cure it, but generally better. And if we really struggle in the ENT clinic, a small number of people, eventually I'll send over to neurology if we're going to have to get really complex treatments. So there's my run through the 4 big episodic and acute vertigo conditions. And I want to spend a few minutes now going through the sort of presentation of chronic imbalance. Now, there is an absolute multitude of causes of chronic imbalance. And whenever I give a lecture to doctors on this, I've said, I always start by saying, thank you very much for inviting me to talk on chronic imbalance. What you've asked me to do is talk on an entire textbook of medicine, because actually almost every bodily system, from arthritis, muscles, joints, nerves, brain, eyes, heart, lungs, all of that can go wrong to cause chronic imbalance. So you'll find when you see me, I go through lots and lots of different bodily systems. And if any of them point in a direction, we'll end up testing those bits. So it can be a challenge to find it. But again, if we can find what's going on, then we can target the treatment. So I thought rather than going through an entire textbook of general medicine, we would look at the one that's most commonly raised in clinics with me and people have done quite a lot of reading about, and that's triple PD. So persistent postural perceptual dizziness. Now we call it triple PD rather than PPPD because PPPD sounds too much like BPPV, if you get my meaning. So it's just easier to call it triple PD, and we don't get confused. And this was first published in 2016. And so you just got to understand, it's not a disease like appendicitis or a broken leg. This is a construct put together to try and simplify the research and management of patients with one type of chronic imbalance. And it's actually been really, really helpful. And what it is a central processing disorder of balance. And by central, I mean brain. So the way the brain handles sensory information, that is input from the eyes, from the ears, and from the joints, which we call proprioception, so visual, vestibular, proprioception. That all goes into your brain, which thinks about what it is, puts it all together, and then tells your muscles and your body and your eyes how to act. And it's the brain not handling that information properly that causes these symptoms of persistent postural perceptual dizziness. And we can look into it with investigation. So this is computerized dynamic posturography, where the floor and the walls move, and we take apart the relative inputs of vision, vestibular, and the joints and muscles in your legs. And if you've got epilepsy, anyone watching's got epilepsy or is affected by flashing lights, can you just look away or close your eyes for the next slide? So we have, this is Burtek posturography we can use as well. And you get put it in the floor moves here. See, this is poor long-suffering Liz again. The floor moves, but rather than the wall moving, what we can do is we can put a variety of different challenging visual stimuli which completely encase you, so completely surround you. And that's a fantastic way of taking apart the different sensory stimuli to try and work out what's going on. Now, here's another one. Now, you can see Liz, as a manager, has been very naughty here. She hasn't got her harness on. So, sorry, that was a mistake there. But her balance is okay. So she has then to follow different paradigms. Here's plane, flying, tilting from side to side. And it just gives us lots of information on the balance system. And we may, at some stage, use this for rehabilitation as well. But it's a matter of trying to get time to do that. So what triple PD brought together were a large number of previous names, such as visual vertigo, chronic subjective vertigo, phobic postural dizziness. There are lots of different terms we used to use, and it's really helpful having it all in one. And here's the symptoms. Now, these symptoms you'll really relate to. A lot of people with chronic balance will relate to. So non-spinning vertigo. I feel like I'm on a boat. I feel I'm moving. Unsteadiness. I'll feel I'm going to fall. Lightheadedness. I know we talked about that as a cardiovascular symptom, but actually it can also occur in conditions like triple PD. I feel I might faint. Disassociation. This is spelled that wrong, haven't I? Disassociation. So that's a really common sensation. I'm spaced out. My legs aren't with me. My brain isn't in the right environment. I'm just not synced. Generally, our patients are worse when they're upright and in motion or surrounded by motion. For example, worse in supermarkets, worse with a panning camera on the screen and motion around you, or scrolling up and down on your phone, which is why if you see me in clinic, I wear a plain shirt, try and sit still on a dark chair and not spin around. And visual hypersensitivity. So this concept of hypersensitivity is really important in balance medicine. The information overload that occurs on the balance part of the brain. And there are three principal triggers for triple PD. One is an acute vestibular event, which we've talked about already. So a vestibular neuronitis, for example, or BPPV, which we've talked about, maybe a head injury. So often there's been something that's damaged the balance organ. You don't have to have had that, but that's very common. A lot of my patients with this have migraine, because migraineurs are hypersensitive to the world. And you know my views on that migraineurs are advanced human beings because they're much more sensitive, and there's probably an evolutionary advantage in having migraine. Or there was when we led simple lives on the savannah. But now we live these hectic lives. As we do, we get overloaded with information. And anxiety, which may be caused by the balance disorder or maybe a trigger for the dizziness. So those three elements mix together to cause these chronic symptoms of imbalance. I don't want you to read this. I've only put this slide in because I know the talk's been recorded. So if anyone wants to look at the technical diagnoses for triple PD, that's it there for you. And the Bharani Society is one of the great world sort of balance societies. So you can just have a look at that on review if you wanted to, or you could just take a photo of it if you want to do that. Okay, so why does it happen? Well, this is a slightly younger me, with definitely slightly younger. He's just left university last week and he's loving life. Someone's just come back from Morocco and wants to rule the world. But this is us over in we're walking to Machu Picchu. We're on the Inca Trail and we are 12,500 feet up. And just behind us there is a vertical drop. How nice is that? And we've talked about this concern of the body freezing when there is a visual stimulus that doesn't work. And if you're over-reliant on the visual stimulus, and it's a good job I'm looking away and not over the edge there, then the body stiffens up. And we've talked about that walking on the high beam, which is a really good analogy for what happens in triple PD. So how do we treat it? Well, we reassure, if we can. We use vestibular physiotherapy to try and desensitize the balance system. And that's really effective. We don't get everyone better, we can't, but we get the great majority of our patients better. And then we can use medications, which we'll talk about, and psychological therapy, CBT, to reduce hypervigilance. And you're getting a theme here that hypervigilance, the brain being oversensitive to stimuli, is a really important factor in chronic illness, such as chronic dizziness. So the medications we use, the poster child, sorry, it's so sensitive here. The poster child medication is, where are we? There we are. Sorry, my mouse is too sensitive. Is venlafaxine. That's an SNRI. It has some issues. You can feel quite depersonalized going onto it, and occasionally, had a couple of patients have had brain zaps coming off it. Sorry if it was you. But you know, it's a great medicine if you tolerate it. Or an SSRI, which is much more commonly used, such as citalopram and sertraline. They can be really helpful just to take the edge off it. And together we get about 80% of our patients better. So that's what I wanted to talk about regarding how I think as a doctor on the common causes of balance. I was a little anxious about doing this because I didn't want to give you information overload. And I know it's an awful lot of information, medical information I've got there, but I hope it's been helpful just getting an idea of how the balance system works and how it goes wrong and what happens when it goes wrong. So what I wanted to do just for the last 2 or 3 minutes is to answer some questions that Kevin has asked me to address, and I think they're really important. Now, these relate to NHS services in Leicestershire, where we have a population of 1 million, but they will be reflected, I suspect, to a greater or lesser extent around the whole of the UK, and are significant. The first thing is, for many years, I've not been allowed to accept patients to my NHS balance clinic who live outside Leicestershire. I have continually battled it, but the problem is our waiting times for Leicestershire patients are so incredibly long. If we were, because we're such a famous centre, if we were to accept patients outside, the whole system would just freeze, and we would just be so completely and utterly overwhelmed. It won't work. So what I've been trying to do over the years is champion local balance centres around the country so everyone can get access locally. But it involves, you need someone who's enthusiastic locally to take it on, because it's hard work setting them up. It's pretty hit and miss around the country. And we've also been contacted, because you may remember the government have said that everyone should be offered, I think it's 5 places that they can go to receive their NHS care at time of referral. So I've spoken to our trust managers and said, does that mean we can put our service down as one of those 5? And they said no. So you can only be offered 5 services if that service is willing to offer you an appointment. So if you're local, you can be offered services, but do just be careful where you accept, because some of the hospitals you might be offered might not have specialist balance services. So just have a careful think and think about who you're going to see if you're going to take that. I also asked our management to give me the current waiting times for new patient appointments in ENT, and it varies between different departments. And they told me this week that the waiting times for new appointments in Leicester for ENT appointments this is ENT, are between 8 and 15 months, depending on what clinic you go to. So I'll just give you a rough idea of where we are here. And that's just for the new appointment, not for testing or anything else. So now on to really happier news, some updates. Now, a number of you very, very kindly gave up your time to assist with the Meniere's disease registry. And this was funded by patients through the Meniere's Society, which is a fantastic support group for patients with Meniere's. And we managed to recruit 411 patients, which is far and away the biggest study of its type in the world. We used 4 major centres. So Leicester, we did very, very well in Leicester, so thank you very much indeed. Guy's, Charing Cross and Norwich. And each of those 3 centres has got a very enthusiastic doctor at the lead. And we have got just so much data. We think there'll be between 6 and 8 publications coming from this. Each publication takes 1 to 2 years to put together. I mean, it is a vast amount of work. So we've got 1 out already. The second one has just been accepted in Otology and Neurotology, which is an American journal. It's much the most famous balance journal in the world. So it's a huge honor to get that in there. So if you contributed to this, you are now famous, and we really thank you for it. But I'm just going to give you the headline findings from the 2 papers. The first one's been published, which is really, I think, quite encouraging, because traditionally we've said to our patients with Meniere's disease, your risk of getting Meniere's in the second year is about 50%, but that's a huge overestimate. And I think that's probably because historically a lot of patients with vestibular migraine were included. So our data is indicating you've got about a 1 in 5 chance of getting Meniere's in the second year, 20% risk. So that's really important data. And of course, the longer you've had your Meniere's, the less likely you are to get it on the second side because of an attrition rate of people getting it over time. Now, the second bit, and Kevin asked me for stuff that no one else knows, and here you are the first in the world to know this. We have had this accepted for publication, so I'm allowed to say it now, but it hasn't been published yet. It's been embargoed. So what we did is we looked at our 411 patients with Meniere's disease, and we went through just huge numbers of other illnesses. I mean, this is really serious computer crunching. It's called regression analysis, and it's quite complicated statistics. But there's only one condition we found that was strongly associated with Meniere's, and it might surprise you, and it's psoriasis. Now you might say, hang on a moment, psoriasis is a skin condition. You get scaly white patches on the skin. How can that be? Well, what we think is going on here is that psoriasis has an autoimmune component. In other words, the body sort of attacks itself. And we think that's what's going on here with Meniere's disease. So we think it's an indicator that certainly some of our patients with Meniere's disease have an autoimmune component, i.e. the body turns on itself and attacks the inner ear. And I think probably that's why the steroid injections into the ear are so successful. So that's a really fabulous piece of the jigsaw. And this is how medicine and research evolve. Hundreds and hundreds of hours of work just to get one small snippet of information. But scientists around the world will be doing the same thing. We're going to get a whole bunch of other papers out of this. So we've got a lot of homework to do over the years. And, we do all of this, up to one every night, just crunching all these numbers, trying to get something out of it for our patients. And I hope that's going to prove really useful going forward. And again, a genuine, heartfelt thank you to all of you who took part in that study, because it makes a difference to other people. Then onto a new study. So with two of the group here, one of my colleagues, Chan Cross, has dropped out because he's didn't want to get involved in the final big study. But my colleagues, it's been led by my colleague in Norwich and another lovely professor, Murden, down at Guy's, and John Phillips at Norwich is leading on this. And we were the co-applicants on this study, and we managed to secure £1.3 million from the NIHR, which is the most respected government funding body for research. So it's a spectacular achievement. And the money goes to pay for all of the support staff, because you need a massive number of people working on it. And you may be aware of ECG. So if you have a regular heartbeat, you'll wear an ECG monitor for 24, 48 hours or whatever, maybe even a month or two, a loop recorder. Well, this is the balance equivalent that we're developing. It's called the CAVA, which is Continuous Ambulatory Vestibular Assessment. And this is, of course, a prototype. So like all prototypes, like an early Apple computer, it's a little bit bulky, but this is what it looks like. And what it does is it records eye movements, motion, a whole bunch of other things. And the idea of it is to try and find a way of diagnosing patients with episodic, we'll go back to the beginning of this talk, this intermittent acute vertigo, which can be so difficult to diagnose because when I see you, you don't have any symptoms. So if you wear this for a month, and you have to wear it continuously for a month, we can pick up the eye movements and changes that occur during an attack. And then we throw it into AI computer, of course we do. That's what we do with everything these days. And we do regression analysis on all the data that comes through. And we hope very much to be able to get a product which we can shrink down over time. We just need to prove it works in 3 specific conditions to start with. And then we may have a way of completely changing the diagnosis of patients with intermittent dizziness. Now, other than being paid a very small amount of money for my time, I have no financial links with this product whatsoever. I have no shares in the company. I have absolutely nothing to gain from being involved in this. So I just put that out there. It's important you know that. We're doing this genuinely for the better good. So what we're looking for is a number of patients who have one of 3 specific conditions. That's BPPV affecting one ear, Meniere's disease in one ear only, or pure vestibular migraine. Now, the difficulty with this is lots of you will have more than one of those conditions. So if you've got vestibular migraine, you might have BPPV as well, or if you've got Meniere's, you might have migraine, etc. You've got to have just the one condition. That's the first thing. And the second thing is it has to have been diagnosed by me, or either privately or NHS, or diagnosed by one of my ENT colleagues in Leicester. Now, the reason for that is we're not able to offer a diagnostic or treatment service with this. We have to have someone who's had all of the workup done, who's been formally diagnosed and still has active disease, getting more than 1 or 2 episodes a month of this. And you have to be willing to wear this device 24/7. You take it off to have a shower and then put it back on for a whole month. It's very exciting because it really has the potential to change the way the world of balance works. And if anyone has that, we have Kevin. I haven't asked you yet. Could you email Kevin? Is that acceptable, Kevin? I'm just looking at you. And then Kevin will forward your details to me. And I'll put you in touch with with the clinical research nurse. Now, it's a very, very specific set of requirements to come in, and I want to be clear on that. I just want to reiterate: you have to have been diagnosed by me in Leicester or by one of my excellent colleagues at the infirmary, just to make sure that this is definitely the diagnosis. Because if we have incorrect diagnosis, it completely destroys the research. Now, there are a dozen units around the country helping us. So if you Googled CAVA, you should be able to get access to your local unit as well. So we've tried to spread it around. So that's really, really exciting. And then finally, coming full circle again, back to the World Service. And if anyone has plucked up the courage to ask a question, it could be your moment of fame and glory. So there we are. There's my talk. And hey, look, I've done it in 45 minutes, Kevin.
Yay!
Are you impressed? I was told to be on best behaviour and not talk too much.
I am super impressed. But if I just add, that is by far the best, clearest presentation I've certainly seen on balance conditions.
Thank you.
I think each year goes by, we're getting more and more clarity on what causes are, and excitingly what new treatments are coming along. So that was brilliant. I have to say, the most depressing part was hearing about the waiting times. None of us know the answer here. As you know, I get to speak with new members who have no diagnosis, and face into the abyss of not knowing when they will receive one.
I think that's right, Kevin. I mean, the problem is, I don't know what the answer is. I mean, when I started here, I've been in less than 19 and a half years now. We had my predecessor who set the clinic up was a brilliant sort of balanced entrepreneur. We had 2,500 appointments a year at the NHS Balance Centre. We've now got 7,500 appointments. And whatever I do, expanding it, the waiting times grow with the expansion. And I think part of the issue is, Kevin, you and I are getting older, but so are all of us getting older. And sadly, dizziness is commoner as we get older. So the whole of society is getting older. And I think that is one of the issues. And then the other issue is the internet, in that we're all able to Google our condition and find out what the centres of excellence are. And we all want to go to those centres. And I think that's one of the reasons that we are utterly and completely overwhelmed. Now we are, excitingly, I didn't say this, did I? Excitingly, we've got funding to knock the Balance Centre down at the Leicester Royal Infirmary, and that will be the new entrance to the hospital. And we're hoping at the end of 2024, in other words, about 15 months' time, to move over to the General Hospital, Leicester General Hospital, with all our shiny equipment, and have a whole floor to ourselves in a new building. So we're going to have a research space there as well. And I don't know whether that'll allow me to increase volume. It might do. And we're also, we've got funding for 4 new consultants as well. So, you know, we are working jolly hard to try and make a difference.
Yeah. Well, we hope, and obviously that the role we play with the group is trying to give support to those who are still waiting for that treatment. You touched on it in the presentation. You did mention an emotional response. And just for the benefit of the new members, to explain, we generally find it after the obvious problems, the symptoms of the balance condition, the most common experience we come across talking with members is the emotional response, which varies between, but if you're a new member here and you're not going crazy, and don't feel bad for feeling bad, it's so normal and human to wonder what the heck is going on in your life. And of course the fear is it going to be like this forever, or is it going to get worse? Is my life over? Why me? All of these things. So I just want to add that for new members today, the emotional response is a huge part of coping with this. And the likes of Professor Ray obviously are there to try and fix us. The problems are between those meetings with consultants is getting on with your life, and that hopefully is where the group can give support to each other. On a selfish note, Lisa, I was delighted to I have many hairs in one side, and it was great news to hear the stats now that it's probably nearest 20%. And there's an example of an emotional response. I've lived with Meniere's for 18 years. Almost every day of my life, I've lived with the fear of Meniere's coming on the other side. That side, it's less of a fear these days. As Professor Ray said, 18 years on, hopefully the odds are in my favour. But it's a lovely example of how your life does change And a lot of this, as well as the treatment for balance, it's understanding how emotionally, mentally, we learn to cope and be stronger with these things. And my final thing on the Carver, please do email me, anyone out there. I'm going to email all of you just to mention again the criteria for Carver for Peter, and then do email me if you think you would like to be involved in this and considered for it. So now, very quickly, because I know we've got, according to me, we've got about 22 minutes of your time left, Peter. We stretch it out. So over to Rupal and Kelly. Let's race through members' questions as soon as we can.
Thanks, Kevin. We have got loads of questions that are in the chat. So Kelly's been across those. But can I just go very quickly first to John, because I know you've got your hand up. John, just introduce yourself. And if you don't mind, if we use this part for the World Service interview, that would be really helpful. So just your name and what your condition is, and then ask your question, please.
Okay, yeah, my name's John Abbott. I've got a bilateral vestibular loss. Just a couple of quick questions for professors. Love to speak to you again. Do you get oscillopsia with triple PD? And also any news on the vestibular implant at all, please?
These are great questions. So oscillopsia is when the world is bobbing up and down. So it's like having a camcorder where you're walking up and down the street, but the camcorder doesn't have any balancing on it. And that's the fundamental part of balance, is to get the eyes moving as you walk. And it's most commonly seen in complete vestibular failure, unfortunately. It can occur in central balance disorders, so tumours of the brain and so on. So we would always get a scan when you have oscillopsia. Generally, as part of triple PD, oscillopsia is not a primary symptom of it, unless you have a severe unilateral or bilateral vestibular failure. So if you've got a big injury to one of your balance organs and you then go on to get triple PD, persistent postural perceptual dizziness, then you can have oscillopsia. Motion sensitivity is a big part of triple PD, but oscillopsia is less of.
Okay, and just secondly, about the vestibular implants, have you any news on that at all, please?
Sadly, well, yes and no. There's a lot of work being done in Holland on this. In the UK, interestingly, we're not doing a lot of work on it at the moment. I mean, it's been led by the cochlear implant companies, and we're looking at not only getting implants put into the balance, electrical implants like a cochlear implant, going into the balance organ, but also potentially using that as a route to put drugs in to try and stimulate the regrowth of the vestibular lining that I showed you earlier in the talk. I think it's going to be a long way off. At face value, it looked like it would be easier than cochlear implantation. They have been implanted, people are using them, but actually the outcomes at the moment are really challenging. So I think it's quite a long way off.
Thanks very much. We appreciate it.
Thanks for your question as well, John. Is there anyone else that's written in the chat box their question that would be willing to ask it themselves, and can we keep it fairly brief, please? Steve, is it Steen? Steen, would you like to just introduce yourself, condition, please, and then the question? Thank you.
Yeah, hi, thanks. So, yeah, my name is Steen. We actually met last year, Professor Ray, you may or may not recall. Yeah, my question is actually on behalf of of our son, a 29-year-old son, who has a severe and debilitating form of vestibular migraine slash triple PD. He's currently completely stuck at home, unable to engage with any treatment that involves any form of travel. So the question actually concerns non-invasive vagus nerve stimulation, for which I understand there are devices that may be used at home. Can you comment on the efficacy of this form of treatment, in particular, the potential for self-administration and administration at home?
I have two answers there. Firstly, I'm really sorry to hear your story. And you say slash triple PD. I mean, they are separate conditions, but migraine and vestibular migraine will predispose you to triple PD. I have no experience of vagal nerve stimulation, so I'm afraid I can't give you any insight into that at all. Sorry.
Okay. Thank you all the same.
All right. Kelly's been watching the chat box, and there's lots of questions, Kelly. So we're going to try and get through them as quickly as possible.
Yeah, definitely. So I'm just going to some people have asked multiple questions, so I'm just going to pick one so that I'll try and get through at least one of people's questions. And then if we've got time, we'll go back to the extra ones people have asked. But Louise has asked, where does MDDS fit in? If you have had this years ago, would this mean you are vulnerable to other vestibular issues, for example, vestibular migraine or triple PD?
So MDDS is Marder-Barkemont syndrome. That's my best French. And so it's a sensation we all get when we come off a boat. If you're on a rocking boat, your brain adapts to that sensation and you come off. But for poor patients who get MDDS, it can occur after any travel. It can occur after car journeys, flights, boats, and so on. And I divide it really into two separate groups. Symptoms of MDDS, in other words, symptoms of being on a boat, are actually really common in those who have vestibular disorders. And that's really treated primarily with vestibular physiotherapy and the standard vestibular treatments. And a very, very small number of patients have a chronic MDDS, which is unrelated to it. It seems to have a central, i.e. brain origin. And there is some research, particularly over in the States, looking at treatments for that. But the data set is really small, and it's only a very small group of patients. So is it associated with migraine? Well, a lot of these balance conditions are associated with migraine as well, but it's primarily a central processing disorder of balance. And that's where triple PD comes in as a really useful, it's very different to triple PD, be clear on that. And one of them is worse in motion, and one of them is worse when you're still. But there is a spectrum of balance disorder where the brain is processing information differently that manifests as symptoms such as MDDS. And I think that's the simplest way of thinking about it.
Brilliant. Thank you, Peter. Next up, we've got a question from Vimla. She's said that she has, now my pronunciation may not be very good, but meningioma on her left temporal bone. And she'd like to know, would this affect her balance?
Okay, so a meningioma is a benign tumour which arises from the lining of the brain and can occur anywhere in the brain. And for the majority of our patients with meningioma, actually, they don't know they've got them, and they're often picked up incidentally because they're slow-growing benign tumours that are often left alone. If you have a meningioma in the temporal bone is that triangle of pyramid of bone that encases the ear. And if it's in the position where another tumour arises called a vestibular schwannoma or acoustic neuroma on the inner ear nerve, the answer is absolutely it could affect your balance because it can squash the nerve of balance. So yes, it's certainly possible it can affect your balance.
Brilliant. Thank you, Peter. Next up, we've got a question from Rosie. So she's put that her vertigo is yet to be diagnosed, but one symptom that she does get is light nystagmus, but all the time, not just during attacks. She struggles to keep her eyes on one thing and have to really strain it and squint to stop her eyes flicking and rolling around. And they'll roll around sometimes when my eyes are closed at night. She hardly ever hears of other people having this constant symptom. Have you come across this, and what does it usually mean?
Wow, well, I mean, that's a symptom that most definitely needs investigation. The commonest form of persistent nystagmus, that's the flicky eye movements I showed you in the videos, is congenital nystagmus. And that's when you're born with flicky eyes and they stay like that all of your life. But if you acquire nystagmus, you have constant flicky eyes like that, you need to see a neurologist, and you need to see a neurologist urgently.
Fabulous. Okay, moving on to Claire. She said that she's got vestibular migraine, which is really well controlled by Pitstephen and Gamorco. Again, pronunciation might be completely off there, Peter, so apologies. But she said that she still suffers with severe motion intolerance. Do you think there's something else going on?
Yes and no. So the Pizotofen is the drug that you were mentioning, which is one of the anti-migraine drugs. And it's a good, safe drug. And we use it in younger people as well. It's one of the ones we can use in children. And it's well tolerated. Occasionally we get a little bit of weight gain with it. But could it be associated with chronic imbalance? Absolutely it can. Could something else been going on? Well, the answer is yes and no. So the yes is that 5% of people get a vestibular, i.e. inner ear related balance disorder a year. And if you get that on top of the migraine, you're going to really struggle. Because remember what we said about migraineurs, they're advanced human beings, super sensitive to everything. The second thing is those with vestibular migraine, which we think about as attacks of migraine, also get chronic imbalance. So it may be part of the migraine syndrome that's causing your chronic imbalance. So the answer is it could be something different. on top of it, or it could be just the same severe migraine symptom.
Brilliant, thank you, Peter. Simon, I've got to your question now on the chat. Do you want to ask Peter your question directly? So again, just introduce who you are and say what your condition is, if that's okay, and then ask your question.
So let me get off mute and refind my question. Sorry, Kelly.
Right, don't worry.
Where's my question? Yes. Hi, Peter. Hi, Peter. My name's Simon Inghooks. Diagnosed with VM just over 6 years ago now. So in that time, I was just wondering if there have been any updates in sort of the causes of vestibular migraine, and likewise, if more is understood about the condition, have there been any updates in the treatment? Because currently I manage it through diet, exercise and relaxation, because I was personally advised that this was going to be better for me than a medicinal approach.
Yeah, I mean, I think we're making slow progress the whole time on vestibular migraine. And as I said, you know, migraine is such a huge topic because 10 to 15% of the population experience migraine, and 1% of the population experience vestibular migraine. So you've been given good advice to really target diet. So cut out caffeine, chocolate, cheese, Chinese food. Don't skip meals. Have a gentle exercise program. Keep yourself fit. Don't use screen time late in the evening. Think about filters on your screen if that's causing problems for you. Don't go to bed late. Have a regular sleep pattern. All of these lifestyle things are really, really important for migraine, and vestibular migraine equally. If that doesn't work, we can then look, if you've got the chronic imbalance, like the question the lady asked just a moment ago, we can sometimes add in vestibular physiotherapy if you've got this wooziness and dizziness during the day. And then if you're having attacks more than twice a day, there's the whole range of drugs that we can add in. Now, the research is primarily on migraine, not vestibular migraine. Right. So what we do is we make an assumption that what works in migraine will work in vestibular migraine, and we use the same treatment paradigm. So whether it's the drug, so I tend to start on low dose amitriptyline, might move on to propranolol, and then we've got these really sort of blood pressure medications, anti-epileptic medications. There's all these different classes that we can use, and you know, there's Botox injections which have got their own sort of believers and non-believers, and there's some very, very expensive new drugs that have been licensed for migraine, which have some efficacy, but they're not. None of them are researched in vestibular migraine. So I suppose the answer to your question is, because it's such an enormous topic and so distressing for so many people, there's lots of money being thrown at the research. And yes, it's inching forward, but no, the world hasn't changed.
Brilliant. Okay, no, that's perfect. Thank you very much.
Thanks, Simon, for your question. We've got a question from, is it SA's iPad? SA, not sure what your name is. Just introduce yourself and your balance condition, please, and then the question to Peter. We've got about 4 minutes left, so if we can keep them brief, that would be fantastic. SA's iPad. Do you want to ask your question?
Gina?
It's Sheila, yes.
Sheila, sorry.
I just wanted to say something
Sheila,
more.
Sorry, Sheila, just tell me what your balance condition is. Just say, hi, I'm Sheila, my balance condition is, and then the question, please.
Hi, I'm Sheila. My balance condition is BPPV, which Professor Ray diagnosed quite a while ago now. I just wanted to say something more on a positive note for everybody out there, really. I've sort of had a bad year last year with my balance and everything, and I let myself get really down. And I then started to reach out and get the support I needed. And I just wanted to say that I think sometimes you need to push yourself. I am now going swimming once a week. I go ballet once a week. I've joined a bowls club and a dance class. And
Sheila, that's fantastic news. I'm really
ju-
sorry to. I'm
it's-
really sorry to cut you off, but
No.
I'm just conscious of time, and that's
Yeah.
fantastic news. We've got 2 minutes left of Peter's time, so Kelly,
Okay.
perhaps one final question.
Yeah, so I'm going to the next one on the list. So it's from Marilena, and she would like, she or he, sorry, apologies, but any advice on ongoing oral fullness pressure?
So fullness in the ear is a real challenge for us in clinic because there's so many different potential causes. So fullness is one of the 4 symptoms of Meniere's disease, along with hearing loss, tinnitus, and vertigo. It can be a symptom of eustachian tube dysfunction. So if you have a congested blocked nose, hay fever, sinusitis, we would treat the nose for that. If it's the Meniere's disease, we treat the Meniere's disease. It can be a consequence of muscle tension. So if you have a balance disorder, whether it's triple PT, vestibulopathy, you tense all the muscles up in the head and neck. So we need to treat the vestibular disorder, and sometimes we add in muscle relaxants. And one of the commonest causes is temporomandibular joint, TMJ dysfunction. That's clenching your jaw, causing fullness in your ear. And for that, we sometimes use a bite splint you wear at night from the dentist, or muscle relaxation medicines such as low-dose amitriptyline. But you've got to get your diagnosis right. That's the key there.
Peter, thank you so much. Kevin, I'm going to hand back to you, and I'm thinking, if people have got experiences to share in terms of, there's lots of comments as well about sort of the emotional effect. We can probably continue for a few more minutes after we let Peter go. Kevin, I think.
Yeah, no, that would be great. If I say, Peter, I don't know if you see all the chat, but so many people saying what an excellent presentation today. So clarity's been brilliant. And thank you so much for giving up your time. Before you go, it's just to let you know, we are getting up a petition to say the only way we're going to let you ever retire is if we can either clone you or replace you with artificial intelligence. Otherwise, we can't let you go anywhere. But,
so I did try and get my son to take over. He's just brought me in a glass of water, but he said I work far too hard, and why would I want to live like that? So thank you. Look, it's been lovely to meet everyone. I've seen everyone up on the screen, so thank you for joining me as well. I am really sorry I've got to go. I genuinely am speaking in Bombay. My lecture starts in 10 minutes, and I hadn't realised it was a huge meeting over there, that they're all coming to watch on a big screen at a meeting from all over the country, and I hadn't realised this. So I've sort of double booked myself, so I'm going to zoom on, try and get my voice resuscitated. Thank you for brilliant questions, everyone, as well. And good luck to everyone, as always.
Thanks, Peter. And
Thanks, Peter.
Bye.
Thank you. Bye-bye. Right, Rupal, Kelly, if you want to see, have we got any more comments, questions, or issues anyone wants to raise? Because we've got about another 10 minutes to go.
I think there's lots of comments on the chat, isn't there, Kelly? Just generally about fear, and people have touched on the stuff that you were talking about, the emotional aspect of how balance conditions can affect us. Does anybody want to say anything on that? I can't see any hands up. Catherine. Hi, Catherine.
Hi. Kevin and I had a conversation a while ago. 7 weeks ago, I had a labyrinthectomy, which was caused because I got Meniere's disease in my left ear. So I found today's chat really, really effective for me. I'm only having a trouble now with the rehabilitation. I've got a physio coming to the house who specialises in vestibular rehabilitation, but she now thinks that I've got vestibular migraine because my recovery isn't quite as quick as I thought it was going to be. I did pop a question into Professor Ray, but obviously you had so many. I just wondered how long that rehabilitation normally takes to get me somewhere near normal.
Does anybody have experience of this? Obviously,
Yeah, I mean,
from a medical perspective.
I say what I know, talking often with those that are doing that treatment, it seems to be as long as a piece of string, sadly. We are all so different. And it's so, you've heard today from Professor Ray, they even are still struggling with clear diagnosis of certain conditions. And I think the the good news, I know this isn't true for 100%, but 99.9% of everyone I've ever come into contact with through this support group and the work I do with VIDA, we get to a better place. Now, for some of us, 100%, it all goes away. For others, we get to cope with what we've got and lead really good lives. I've lived with Meniere's for 18 years, and I've had a wonderful life. I'm better because of what I've had to face up to through it, ironically. I wouldn't wish it on anyone.
No.
But we all find out, you know, it's that awful cliche, the new normal. The trouble is, we don't know until we go along this journey what that new normal eventually will be. But I've got to tell everyone the great news, things always get better. And even if symptoms didn't get better, we get better at dealing with it, dealing with all that baggage that comes with it. How relationships are affected, how work is affected, socializing, how we're affected in how we see our own worth.
Yeah.
Stuff.
The question was about fear, and the one thing that I have to say is the labyrinthectomy has taken away the fear.
Brilliant.
The fear of those awful violent attacks.
Well, you'll know now that gives you so much freedom.
Yes. Oh, yes.
Forward. It's always like empowering you once you can start shaking off that fear. And I know I remind myself of what I was like in the first year. I was scared almost to death. I had no idea. Literally didn't know which way was up. So I understand if you're at the early stage of this journey, listening to someone say, get rid of the fear, they'll sit there and go, yeah, who are you kidding? But it does come. Back to your original question, in terms of how long does it take with rehab, it really is a unique individual. I'm sure there are averages that, such as Michaela Burton will tell us in August, but I'm sure she'll confirm we're all individuals.
Yeah.
We all, you've got to take into account our ages. Are we fit? You know, I now fortunately I go and run, and I'm on a mountain bike doing crazy things up and down hills. So I consider myself so lucky to have come through this and be able to live more or less a normal life. So keep faith, and as they always say, do move as much as you can. Get moving, and that will help. Have we more comments?
I was just going to say, Kelly, that there was quite a few comments online, not there?
Lots of comments about kind of how informative Peter's presentation was and how helpful it was. And there's been discussions about the fear and various other bits and pieces. I think one of the questions that came out, I've lost it now, hang fire, is from Louisa. She was asking about, apart from Meniere's, do other people with vestibular conditions come with tinnitus? I was just wondering what people's experiences are, whether they can assist Louisa with that.
Well, all I can tell you, I know tinnitus appears to Meniere's related to the hearing loss. It's almost
Kevin,
as though the brain.
Sorry, Kevin.
Yeah.
Helen's got her hand up. Just can we
go
jump over to Helen?
Yeah.
Hi, I have an acoustic neuroma, and I also have triple PD, and I have tinnitus.
And have you got hearing loss with those conditions?
Yes.
Yeah. So again, my crude understanding is tinnitus a lot of the time is the brain missing certain signals and almost inventing its own noise, sadly.
Yeah, I knew I'd had hearing loss for a number of years, and it was actually in the kind of the initial panic of going and emotional trauma of getting the diagnosis of an acoustic neuroma that the tinnitus started, and it's there 24/7, but a lot of the time I can just ignore it, whereas 3.5 years ago, it was this screaming, horrendous, numerous sounds in my ear. And it was incredibly painful day to day. But when I talk about it, I tend to tune into it and hear it more. if it's the house is very quiet, it's there. But yeah, most of the time I can just tune out.
Yeah, thanks, Helen. Can I just, sorry, Kevin, Louisa just says, I don't have hearing loss and it comes and goes. And I'm going to go to Claire because Claire's got her hand up. Hi, Claire.
Oh, hello. I was just back to the fear question and Peter's mention of hypervigilance. And I would just say that, I first got problems with vertigo 10 years ago, and I am massively better. And I put a lot of it down to mindfulness and mindful self-compassion. And I would highly recommend Breathworks. They have a community of practice which has a support group specifically for people with dizziness and balance disorders. I think finding ways to soothe the system in whatever way one can when the fear comes on is really helpful to break that feedback loop between the fear and the dizziness and the dizziness and the fear.
Yeah, thank you, Claire. Kevin, we've got like a minute to go. Can we just talk about the, particularly for some of the new members, the member-to-member support, the Facebook group, etc. That would be fantastic.
We've got more people than ever on it's called M2M network. Basically, you opt in, contact myself, and by opting into the list, you're agreeing that your email and or phone number and only first name can be shared with other people that have opted in. The great thing about that is you can then reach out, normally by email or text or WhatsApp, to fellow members who are just like you. We on the list, we also do list your recent diagnosis if you've got one. But the key there, you'll be amazed how all of us, whatever flavour of disorder we've got, I honestly feel we've got a good 50, 60, 70% of commonality in all the challenges we face. So what I would say, if you're on the M2M list already, don't restrict your contact to people who've got the identical diagnosis. And the most amazing thing is, when people reach out and people are being supported by that contact, it's also a really positive effect on you for reaching out and engaging with others. And it's that two-way conversation that somehow helps heal us and gives us more confidence. So again, if you'd have met me 18 years ago, I would have said, don't ever join a support group and keep it all to yourself. Totally wrong. I was an idiot. I know better now, and I hope people will benefit from that experience. Do join the M2M and do contact loads of people all the time. When you can, if they live locally, arrange to go and have coffee. That'll be a real thing, getting out and meeting. Thanks, Rachel.
Thank you. Thanks, Kevin. Claire, just somebody's asking, can you just share the mindfulness group you just mentioned? Oh, you've just done it. Breathworks Community of Practice. You can actually save the chat. If you click on the three dots, you should be able to save the chat. It should give you the option to save chat. So if you've missed anything in there, or email addresses or contacts or whatever, you should be able to do that on there. And of course, all of these are recorded as well. And Kevin's really good at keeping across all the important stuff that you need if you wish to. So thank you so much, Kevin, Kelly, and of course to Peter Ray, and most importantly for you guys for coming along, because it's about us. It's about all of us that have had, have balance conditions and live with it on a daily basis, and to share that with each other I think is really important. So from our perspective, I think Kelly and Kevin, thank you so much.
It's been really good, and thanks everyone who's turned up today. It's been great to have that participation. Lovely questions for Professor Ray as well. And so remember, do refer to the website. I've just put a link in there to one of our pages that deals with members' tips on coping with anxiety. And there are some really good links on that page as well. But thanks everyone for taking part. We will get to better places. It does happen. So keep hoping. The hope is there. Good things are going to happen. And in the meantime, we're all here to support each other. So thanks very much for another great meeting. And we'll see you all again in August. So thanks everyone.
Thank you.
Thank you.
Bye.
Bye-bye.